How did you sleep last night?
I slept great last night, actually, and I guess I haven't been sleeping great lately, as of late, and I think it's because of the heat, like you said this morning. You know, it was kind of hot last night, no AC, but, once I'm in a pretty good routine. We talked about it before, where, I get to bed the same time. Betsy and I go to bed the same time, and we read for a little bit, and that kind of helps dial it all down, and then go to sleep. We don't do the phone thing in bed, so that definitely helps. And then usually it's right about the same time. It's like, I'm starting to feel it. She goes to sleep. I turn the light off. We're good to go.
Routine is important.
So why don't we start this little bad boy off with who you are and what you do, and then we'll kind of go from there.
Okay. And I want to be clear, I'm not here like trying to get patients or anything, so I'm going to try to leave out anything that way, but I am a physician assistant, and I work at the hospital locally here in the sleep clinic. I did my undergrad work at Palm Beach Atlantic, is where I graduated with a bachelor's. I did half of it at Central, but I got my bachelor's in science, majored biology, chemistry, had some psychology in there. Initially thought I wanted to go into dentistry, so I was gung-ho. I was applying for dental schools. We ended up moving to Phoenix, and that's where I got an internship at a dental office, and I was kind of like, yeah, I think I like it. I really thought I liked the salary, I think is what was really appealing to this. So after about a year of working there, we ended up moving back home, and we moved to Manistee, and I'm kind of looking back and forth at applying to dental schools here, and decided that I really honestly did not like dentistry as much as I thought I did. So I started working with Dr. Henji's office. He's ENT in town here, and I was with him for a couple years.
Dr. Henji's good shit.
Him and Dr. Mendians, love them both. Learned a lot. Really kind of sparked a lot for medicine with that, and so was looking at what else I could do with my biology degree, and I really liked medicine and everything, and ended up finding the Grand Valley program in Grand Rapids for physician assistant. And so I applied, got in, I didn't have a great idea. It was fairly new. I didn't see like a lot of PAs. It seemed more NPs than PAs. So kind of just...
PA is a physician's assistant?
Yes.
And an MP is a...
NP is nurse practitioner.
Oh, NP,
yes,
gotcha.
Sorry. Pretty much about the same thing, just different ways of getting there. But...
This episode is brought to you by Chapo's Northside Bar, voted best burger and wings in town. Yeah, you heard that right. If you're going to go out for a burger or wings or both, you might as well go to the place that's voted the best. The best. Why wouldn't you have anything less? Look, and if you're not down for a burger or wings, that's cool. They've got salads, wraps, and sandwiches also. And this summer, it's going to get wild, because on June 24th, it kicks off their summer concert series in the parking lot. Live music, folks, and guess what? It's free. Yeah, come down for the music, stay for the fun, enjoy the best burger and wings in town. Chapo's Northside Bar. This episode is brought to you by Just Clean, Manistee's premier car wash, located at 146 Cleveland Street, or just north of the US 31 bridge. Look, if you're anything like me, you're not going to spend an hour or two in the hot summer sun in your driveway trying to wash your vehicle. I don't have time for that. So I always take my truck to Just Clean. I choose their ultimate car wash, which includes a triple foam conditioner, a ceramic coating plus wax, and a 60-second heated blow dry. They are the only car wash in town offering the ceramic coating. For my money, I choose Just Clean, and I hope you do too. This episode is brought to you by Brandon Ball, broker-owner of Dwelling Realty in Manistee, Michigan. Listen, are you looking to sell your home? Then look no further. When you list with Brandon Ball, you'll get a trusted advisor who will guide you through the entire selling process. With extensive knowledge of the local market, he'll help you price your home competitively to attract the right buyers. And with proven market strategies, your home will be seen by the most qualified buyers. With his 17 years in the business, you'll have someone who's experienced and on your side. Contact Brandon today to get started selling your home. 231-690-4981 or Brandon at dwellingrealty.com.
in any case, yeah, fell in love with it. I've really been very thankful that I went into this the way I did. It wasn't like something I knew I was going to do growing up or anything like that. And then after I graduated, it was a lot of commuting for a couple of years, about 3 years of commuting, got my master's, and you do a lot of rotations on their last year and a half. So every month or 2 months, sometimes it was every day going in primary care, surgery, ENT, this, that, or the other. Never once did sleep. It was not on the radar at all, because I thought sleep apnea, boring. Like, nobody wants to do that. So it was interesting. I went into primary care, really loved that. My second pregnancy, unfortunately, was a little complicated, and I had some issues just juggling the time management stuff and everything. So I'm like, I got to find something else. And so I was really kind of looking for something part-time, but I couldn't find anything part-time. And the hospital at the time had a listing for the sleep clinic and stress tests. So radiology. And I applied for it, and I was went and did the interview, and I was kind of like, this is kind of intriguing. And the physician working there at the time was Dr. Quimby. And he, being a board-certified sleep physician, like, he had to get his medical degree, then he was a pulmonologist, then he specialized on top of that for sleep. So this is not like an easy field to just get into. I had to do extra training with him. It was essentially a year and a half of very intense. Every patient I seen, we reviewed, and we were on the phone at nights and during the days, but it was just a whole different feel in sleep. It was kind of cool that I felt like I was actually helping people, which was really nice. And then it's kind of transitioned from there. I've been doing it about 4 to 5 years. Actually, my 5 year just came up. And I feel a lot more confident in it. I'm still not a board-certified sleep physician, so as a PA, I work with our physicians. Dr. Quimby has sadly retired, and we are hiring new, which is going to be great. And I still have Dr. Boss is up in Charlevoix, and Dr. Milliken actually retired too. So we're in a little bit of a transition right now. But my training-wise, as far as sleep, has been hands-on direct with my overseeing physician. They have to sign off on things and make sure if we have questions or whatever they're comfortable with us seeing, that's what we're able to see, essentially.
Okay. But you do the majority of the work.
Yes. Yeah. Now, especially in the Manistee office, because we really don't have a physician in the office full-time at all. Previously, Quimby was there once a week, and Dr. Milliken was every other week. And the more comfortable they get with that, the less they come. And digital world's out there now, so a lot of like Zooming. I don't think we really necessarily need somebody in the office unless there's specific patients that we want seen by them, which does happen on occasion.
So is sleep apnea like the top? That's like the main thing, and then there's. I do want to talk about sleep apnea. Yes. But if there's other issues that can fix,
I'd say 90% of it, honestly, is that we see is sleep apnea. That's what people get sent to us with. But I mean, there's insomnia, there's restless legs, there's REM behavior disorder, there's circadian rhythm dysfunction, there's narcolepsy. There is a lot in the field of sleep. And then if you're looking at pediatrics, that's just a whole nother ballpark. We don't do peds here. That's got to be like it's got to be a DeVos type thing. But yes, so there's a lot to it. But I would say 90% of what I see is sleep apnea. And if you're looking at like an organic problem that needs to be fixed, it's probably one of the most important ones because breathing is good. It's always interesting to see what people think sleep apnea is. Okay, so I kind of want to ask you what you think sleep apnea. I mean,
somebody who's like just mouth breathing the hell out of their night, mouth wide open, snoring.
That's what I get every time when I'm talking to patients and they come in. Like, what do you think sleep apnea is? And they always say snoring. I'm like, it gets caught snoring because it's loud and it's disruptive. I was like, but sleep apnea is not snoring. Okay. So we always kind of start off with that, and I think that educating patients on what sleep apnea is very important, because a lot of people have this mindset of, I would never wear one of those masks, and it's not even like you have to, but they just think it's snoring, and they're like, it's not a big deal to me. I'm sleeping fine. Bed partner's unhappy, but like, it's not bothering me at all. But really, sleep apnea has nothing to do with your nose. And snoring is literally just turbulent air going in and out of the nose. Like you're actually just bragging that you're sleeping.
Last night in bed, that's the one thing Betsy was like, hey, snoring. Excuse me, because I don't snore every night. I'll go weeks. You know, maybe I have a few cocktails.
Yeah.
That'll cause me to snore. But sometimes even when I don't drink, I'll snore. So that was one of the questions she wanted. Like, is sleep apnea snoring, or what is snoring?
It's
so
not.
that's it.
Snoring is just a noise. Although it's hard to differentiate for people. It can disrupt your sleep, because if you're snoring and the bed partner's bothered, you're going to get elbows. So that will pull you out of some deep sleep.
Definitely.
But sleep apnea is actually the back of the throat. And as you fall asleep, essentially your body becomes more and more relaxed. And actually in REM, your brain goes into a coma-like state, and your muscles just become paralyzed. So the deeper sleep you get in, it's all based off of the back of where the tongue and the throat going down is. It's all muscle. And the progressively deeper sleep you get into, the more this is to close off or obstruct. So your airway literally closes off. So you're suffocating at this point.
Yeah.
You cannot get oxygen down to your lungs, and so your oxygen levels come down. So apnea, by definition, we usually look for apneas and hypopneas. So you stop breathing, airways closed off to the point that your oxygen levels are coming down 3%, 4% or more, 10 seconds or longer, followed by an arousal. That's one apnea, one hypopnea, depending on the degrees of these. So it's actually doesn't have to make a noise, but a lot of times you fall asleep, airway closes off, you're suffocating as your oxygen level comes down.
I'm laughing because that is my dad. When I was growing up as a kid.
Everybody knows somebody.
Oh my God. You just hear him just howling, snoring so loud. And then all of a sudden, and then, I'm back. I'm back.
And it's funny when you talk about it, but people get very concerned when you do recordings and review the information with them. Like, your oxygen got down to 64 last night. They're like, what? Yeah, that's not a good number. But the lower your oxygen goes, at some point your body has to respond. So instead of nice, deep, restorative sleep, you're getting shots of adrenaline essentially all night. Wow. And unfortunately, if it's happening enough, it could cause a stroke, heart attack. You can develop cardiac arrhythmias. So that's where that's the organic stuff. I need you breathing at night before we can do anything. But it's a big difference between snoring and sleep apnea.
Gotcha.
And there's different forms of sleep apnea, which people don't realize either. So there's obstructive, airways closed off. There's central sleep apnea, which central sleep apnea can happen a couple different ways. I think the heart, I don't know why, center of the body, I guess, but your heart beats, pushes blood through the system that has your oxygen in it. And if you've got, say, heart failure, a very weak pump, you're not able to push blood out as well. You're not able to oxygenate as well. And at night, when you fall asleep, your heart rate comes down. So you'll get these kind of like dips. We call them Cheyne-Stokes respirations, where oxygen levels going up and down and up and down. Unfortunately, your body is not responding well to this. Completely silent versus obstructive sleep apnea. You get the as the airways popping. No, completely silent. Can happen with concussions. Central apnea can come from the brain as well. So we breathe. We don't think about it. It's kind of nice. But if you've had a head injury or a stroke or are on medications that possibly are suppressing the breathing centers, you can just stop. You forget to breathe at night, essentially. Oxygen levels still come down. You get a little bit more of a breath, a heavy breath, but not so much of a abrasive opening of the airway.
So you could die in your sleep.
Yeah, I mean, it's not a bad way to go, but it's it's not. I get that response all the time. Yes, if I was going to go, it's going to have to be something chronic though,
Okay.
not something that happened one night because you did have, unfortunately, had some drinks or it's a wedding and you had a lot of apnea that night. But this is something that has to go on 10 to 15 years. But if you have, we divide things. There's mild, moderate, and severe sleep apnea. Moderate sleep apnea has the cardiovascular risk. Severe sleep apnea doubles, if not triples, your risk of the strokes and heart attacks and cardiac arrhythmias. So the higher your risk, the more likely it is to happen. But 10 to 15 years of untreated sleep apnea is usually where we're like, yeah, you're gonna start having issues with arrhythmias, flipping in and out of AFib, or developing heart blocks, maybe having a stroke. And you can have the stroke during the day. You can develop the heart arrhythmia during the day, and it all can come from all the stress your body's undergoing at night. Just trying to breathe, just trying to reset. But it's interesting because sleep it's the one healthcare field people can't really tell you what's happening. So you don't know what's happening until...
Yeah, I was just going to say, like, what are the signs that people should be looking for? I mean, they'd have to have a partner in bed with them to probably help them.
Partner is extremely helpful. And a lot of people don't have partners. And a lot of times, though, it's been going on so long that it's kind of like...
Yeah, they're used to it.
Yeah, it's fine. They've been doing this forever. So symptomatically, I always tell people, you don't even know how bad you feel till you're going to feel better. Because this probably starts for a lot of people in their 30s. And it just slowly, progressively worsens over time where you're having difficulty falling asleep. You're waking up multiple times a night. You wake up and you're still super tired.
Yeah.
But they don't think they're tired. There's like this is how I always felt. It's normal to fall asleep in the car at a stop sign. No, it's really not. So sometimes the self-awareness part is hard for people because it starts and it progresses, and it's usually not until you're moderate to severe that it really starts to become a problem where negative health effects are going to result in it getting caught. But usually multiple nighttime awakenings, bed partner saying that, kinds of morning headaches, waking up with a morning headache is a big red flag that you are having apnea.
Really?
Mm-hmm.
So you go to bed and you haven't done any drinking, you haven't done any drugs, whatever. You just, normal night, you go to sleep, you wake up in the morning, and that could be because you had some form of sleep apnea.
Yes, because most of the time, if you've got migraines, headaches, anything like that, say you go to the emergency room, the goal is to knock you out. We want you to sleep because your brain needs to reset, essentially. It's the easiest way of thinking of it. But you're going to get loaded up on things that are going to make you sleepy. You pass out, you wake up, and the headache's gone, or migraine or whatever. So if you're waking up with headaches on a routine basis, not just a week you were sick and you had an allergy or something going on, or a sinus infection, it's got to be like 3 or 4 times a week, pretty routinely throughout the year, or maybe throughout 2 to 3 months, I would say even, but just not like a 1 week basis, I guess is what I'm saying. More chronic. Everything in sleep is about chronic. So I'd say 3 months.
So what does it look like when somebody comes in for to go through like the process with you and get into the sleep study?
A referral. It's always good to talk to your primary care provider. I get a lot of referrals though from cardiology, from urology, nighttime urination. That's a big one. 1 to 2 times when you wake up to urinate or reposition, probably within normal. 3 or more though, they're obviously, if it's a male, they're going to check prostate, make sure there's no prostate cancer concerns or anything. But from there...
Get it checked, boys. Get it checked.
It's mostly just blood tests now. Luckily.
Is it?
Yeah.
That's good.
Usually. It's rare, I think. I'm pretty sure. I'm not in primary care anymore. But aside from that, sleep apnea causes nighttime urination because at night when you sleep, heart rate should come down, muscles should, your body is relaxing, your heart pushes blood through your kidneys, that's how you produce urine. So at night, if everything's winding down, you're going into a coma, which is like the deepest state of relaxation, you shouldn't be producing urine. But if you're having apnea, you're getting these shots of adrenaline all night, and your heart rate's going up and down, your muscles are contracting. You're actually perfusing blood and you're producing urine.
Yeah.
And you really shouldn't be. And if you drink a gallon of water, a couple drinks, alcoholic drinks will do it too.
Yeah, alcohol's going to do it.
Yes.
It does it for me. When I don't, I sleep and I drink a gallon of water a day.
Yeah.
So, no problem.
Yeah.
Have
Pee
a couple
before
of
you go
beers.
to bed.
Yeah.
Like 2 hours, well, they say 4 to 6 hours before bed. Try to just limit what you're drinking. But definitely get a lot of referrals from urology too. And then it tends to be, though, all these referrals, like primary care wise, it was a bed partner. It's kind of a joke that there's the elbow sign.
Yeah.
In medicine, there's all these signs and surveys and stuff, but 75% chance you have sleep apnea if you're getting elbowed at night by your bed partner. Is pretty accurate. I'm always yeah.
Wow.
Now, it might be mild apnea, though, and so that's not going to have the cardiovascular risk necessarily with it, but it is disrupting your sleep, and that can kind of cascade out of control where you're not sleeping well, metabolism's not resetting at night, you have low energy, you don't have as much energy during the day, you gain weight, that worsens the sleep apnea. So this is just that continuous process. Then once you're into moderate to severe, then we're a little more worried about the strokes and heart attacks and that sort of thing.
What does the sleep study look like when they're in there sleeping? Like, how do you get them to sleep? That's the one question I had. Was
They're
like,
tired.
I'm gonna come in there and then you hook me up with all this stuff. I'm assuming.
Well, you probably don't have a sleep problem. People who come in, they're sleepy. These are they're not getting sleep. A lot of times that we have some screening things. There's an Epworth score, and you go in and it's on what are the chances of falling asleep doing this? It's like 12 questions, and at the end you total it up. And that's how we gauge, are you sleepy or are you tired, fatigued? Like two totally different things. We're worried about sleepy.
Right.
I don't want you to fall asleep. We've had people fall asleep on a roof, fell off, broke their neck. Like these people are sleepy.
Yeah.
So when they come in, rarely do we have a problem with somebody not sleeping. There is an insomnia overlap syndrome. Some people, oftentimes women, present more with insomnia, where men often are the narcoleptics. They fall asleep and they're doing the women, it's like it's such a stressful process not breathing at night that they just resist doing it. So we do have a little bit more of a problem with the insomniacs and getting them to fall asleep, but they always eventually do. We don't need to see a ton of sleep. We record for at least 6 hours. 2 to 4 hours. 4 hours would be great, but never has anybody came in and I expect them to sleep 8 hours. You wouldn't be in the sleep clinic if you slept a perfect 8 hours every night. So, but we do a lot of home sleep studies mostly. So a home sleep study, you take the device home and you sleep your normal environment and everything. But there's a little belt you put on, a thing on your finger, nasal cannula. When you're ready to sleep, you turn it on. When you're done sleeping, you turn it off. It sounds simple, but I
could see it being difficult.
It's
really
harder to do than people think. Especially if you have apnea. Every time you have apnea, you're basically moving around. So people are tearing them off and they're breaking the devices. And there's just some instances like with the central sleep apnea, we can't diagnose central apnea with a home apnea link. So then it's like, all right, yeah, we do need you to come in for an in-office study, it's extensive. We're working on it, but it's kind of funny. You come in and I tell people, you're going to look like Frankenstein. We're going to put stickers on your head. Cool part of that, we can see your brain waves all night. I can tell you what stage of sleep you're in, how much. And seeing that for some people, it's like, wow, like that's crazy. I got no deep sleep. Or like just little bits of that. That's helpful for people. We don't get that from the home sleep studies, though. You have EKG, belt on, thing on your finger, nasal cannula, and then they're recording the whole night. So if people are having like sleep-related hallucinations or
what's that?
It's just what it sounds like. You're waking. It's upon falling asleep or upon awakening. People who are really chronic state of exhaustion are not transitioning in and out of that deep or the sleep architecture normally. Their body's kind of wanting to keep sleeping, so you can hallucinate. You can hear or see.
Like you're stuck in the dream realm.
Yes, and
Wild.
It's pretty crazy, and it's been going on a while. So people will be like, "Yeah, that guy comes in here." Oh, okay, that doesn't bother you? No. Or they'll hear something like the doorbell ringing or something along that. But it's nice to be able to tell them, like, okay, that's not normal.
You're schizophrenic.
It used to be easily misdiagnosed that way, honestly. And people were like scared to bring up, like, no, it's actually, all it is you're tired. Your brain is like not wanting to wake up and you're pulling some dreams up. The other one is sleep paralysis. Have you ever had it? Most people have had it at least once or twice.
I think I have.
Probably. So you wake up and you're like paralyzed.
And you can't like move.
You can't move anything but your eyes. And it's because your brain is stuck in REM. And in REM, rapid eye movement, you can move your eyes, but the rest of you is paralyzed. So you don't have function to that. But if you wake up and you can move your eyes, but you have no function to the muscles here. So you can't take a deeper breath, but you're kind of starting to panic a little. So your heart rate's coming up and you feel like you're suffocating. It only lasts like a minute, maybe 2. It feels like a lifetime, though. It terrifies people.
Yeah, sure.
Oftentimes caused by something happening in your sleep, something disrupting it. There is instances where that's a pathological thing, and there's medications that can help. But ideally, we try not to do medications. We try to get people off medications. That's kind of the fun part.
Yeah, I want to talk about medications. Like, let's start with an easy one that you can get over the counter, like melatonin. Because I have taken melatonin.
Yeah.
And I took it for a while, just because of chaotic schedules. I wanted to make sure that I was going to fall asleep right away. But man, it made me feel like shit in the morning.
Some people. Yes. So I'm not advising anybody to take medications or anything. So I always think you should talk with your providers about, is it the right medicine for you or not? But it is over the counter. So a couple issues with that right off the bat. When the FDA doesn't regulate, there's nobody regulating. So when they do, the American Academy of Sleep has done studies, and they pull melatonin off the shelves. They'll test it to see how much melatonin is actually in it. Very inconsistent. Some of them have none. Some of them have way more than they're listing. Every month it's different. So you do have to be kind of careful with the brand that you're getting.
To speak to that, like there were times where I would look like the 5 milligrams, let's say, or whatever it is, the low dose, take one, and then 20 minutes later, I'm in a coma, if what it feels like, and then some days it's like, I'm not even tired. So that's wild that some have inconsistency in what. Very
inconsistent over-the-counter stuff. There's a name brand that they do rely on a little more. It's Natrol, Natrol. And that we use for, as far as like treating patients for REM behavior disorder is what we treat. As far as a sleep aid, though, melatonin's wishy-washy.
We produce that, right?
Yes. Yep. I guess that's probably a good thing to go over, as like, how does melatonin work for us? Because people do take melatonin probably incorrectly. Even that saying, like, I take a low dose of like 3 or 5 1 milligram is considered like a low dose. Once you get to 5, 10, 15, 20, I've heard people on like 60 milligrams, Jesus. Like, oh my gosh, that's way too much. But low dose would be considered more like 1, 2, 3 milligrams. And then the higher dose you will get more headaches in the morning, grogginess, side effects that kind of way. But the timing of it is important. So our sleep is ran off of our circadian rhythm. So our circadian rhythm is this internal clock in our brain. Actually, if you could go directly through the eyes to the center of the brain, it's a hypothalamus. There's a suprachiasmatic nuclei. I just like to say it. Once in a while, I got to say it. But that is where our circadian rhythm is run. And so I always think of this as like a little off and on switch. We are not nocturnal creatures, and this is why. Because this clock is in our brain telling us this is when you sleep, this is when you're awake. In a perfect world, if I could take you and put you on a deserted island and remove all modern conveniences, we'll say.
Right.
In the morning, the sun comes up. Even with your eyes closed, your brain can sense the sunlight, and it flips on the awakening switch. So keep in mind, in Michigan, for the past 6 months, this hasn't been happening. So this really throws people off. So essentially, your awakening hormones turn on. There's this complex play of hormones to wake your body up. You're awake all day. And then at night, as the sun is coming down, your brain gets less light exposure and starts to release melatonin. So think of melatonin, though, as kind of like a trigger, I suppose. So, and it's not an off and on switch for the sleep. Your body starts to prepare for sleep. Gotcha. So melatonin starts to release. You get tired, more and more sleepy. Sun finally sets. Let's say you fall asleep at 10 or so. Melatonin continues to increase and should peak around 3 or 4 in the morning, then naturally start to decrease and naturally start to slowly awaken the body. But as it's slowly coming up, your heart rate's coming down, your digestion's changing, the way you manage your glucose and everything. It's a lot of advanced physiological processes going into preparing your body to sleep. Melatonin doesn't do it all on its own, though. It kind of like touches base on all these other hormones that help hopefully get you to that point. And if you can get that nice melatonin peak, you're more likely to be able to obtain the good sleep architecture that everybody's kind of like shooting for with your sleep stages and stuff.
Right. So it sounds to me like taking melatonin is going to F that all up.
It could. It definitely could, especially if you're taking like a huge dose at 8 o'clock at night.
Yeah.
I mean, your peaking.
I
don't even, it's hard to say how you're going to do it. There's sampling. You can do melatonin sampling, but it's completely not available. You can't do it really. It's too expensive and everything. But you can just really screw some things up. If you are taking melatonin, I ask patients to take a very low dose, like 1 milligram, and take it at the same time every day. Try to think of it as this is the sun's coming down. Here's your little sleep cue, we'll call it. But just be careful with it because it can interact with other medications, and just make sure that you are talking to your physicians, your providers and stuff, that it's a safe choice for you.
So I'm not asking you to speak for doctors or anything like that or medications. I'm just really curious about this part right here. So we're getting people to a sleep study. Like you said, we're trying to get them off of some of these medications and stuff they're on. Why would somebody be... Well, first, why don't we talk about Ambien? I've heard some wild shit about Ambien.
Ambien is, it's a hypnotic sleep aid. It's a big deal. What are your questions about it? Let's go with it.
I mean, I've heard like people just like waking up and not even remembering an entire day. Yes. Sleepwalking, which I'd love to talk to you about that too. Not knowing what they're doing at night. Doing things. Yes. And having no memory of doing them. All
right. No, I can answer that. So if hypnotic sleep aids, they're strong. So these are things that are going to put you to sleep and potentially keep you to sleep where you're not responding to your body's natural cues, I suppose. So hypnotic sleep aids, you should not be prescribed a hypnotic sleep aid unless sleep apnea has been ruled out. Because if you take any kind of sleep aid and you have sleep apnea, it is pushing you deeper into sleep. Your body is not responding. Your oxygen levels are going lower, and you are going to do weird things. So anytime anybody says, I took Ambien, I had sleepwalking and all this, you could be mixing it too. So if you're mixing it with marijuana, alcohol, other medications, I mean, that's going to really... Ambien needs to be... It is highly regulated. It's a controlled substance. Definitely not something you want to take of your friends or anything like that. But most of the time, providers won't prescribe it at all unless you've had some form of a sleep study to verify that you're at least breathing that night, because otherwise you are more likely to do some crazy things. Aside from that, though, if we'll use it, like if people are having a hard time adapting to a CPAP or something, or it's the insomniacs oftentimes just getting their body to encourage some deeper sleep. But you have to have your therapy, and it doesn't have to be CPAP, so I do want to throw that out there. But without it, it could even cause a stroke or a heart attack, I guess, in some people who have had the chronic apnea and stuff. It's contraindicated unless the organic problems have been ruled out.
So more than likely, the physician, your physician, should be saying, well, why don't we get you sleep tested before we put you on?
Yeah, or at least they're looking at you. I know that in screening, like, do you have the risk factors? But I think it's pretty common now. A lot of times they're just like, no, let's at least do a screening of some sort. Primary cares like to do an overnight pulse ox. You just sleep at home with a little thing on your finger, record your heart rate and oxygen all night. It can't diagnose sleep apnea, but it can give you a pretty good idea. There's the pattern of your oxygen. It's like straight, and then it comes back up, straight, and then it comes back up. Oh yeah, you probably have sleep apnea.
I mean, yeah, oxygen has definitely been something that people have been checking a lot more lately because of
the watches and stuff.
The pandemic and stuff like that.
Yeah.
You know, everybody. So I mean, and I was tracking my sleep with not this one, but I had another Garmin for a while just to see how I was sleeping. And I mean, what are your thoughts on wearables like this?
I like them.
Okay.
They're not super accurate, so you have to take it with a grain of salt. Mine last night, I just got one, so I'm kind of playing with it, but it's like shooting little lasers in my eye last night, so I was like, I gotta not sleep with this thing, but I like looking and seeing. I feel like it's pretty reliable. Most of it that goes off of heart rate regulation, or variation, I'm sorry. So if you're on blood pressure medications that, dampen your heart rate regulation, it's going to be very inaccurate. A lot of medications will cause changes to your heart rate regulation. So it's something I think is helpful for people, but it's a little frustrating when people come in, they're like, it says I got no deep sleep. I'm like, but how'd you feel in the morning? They're like, well, it said I didn't sleep good. I'm like, I don't care what your watch said. How did you sleep?
Yeah. How do you feel?
So just taking it with a grain of salt, I guess. But I think they're helpful. But they err too.
So what is, like, we almost got there, was with the sleepwalking, and the I mean, even if you're not taking a controlled substance like Ambien, I've had people tell me that, make a sandwich, don't remember making a sandwich, or I knew a guy that said he had to sleep in a sleeping bag with his arms inside, zipped all the way up, because he would get up and just like get in a car and drive places. And
no, it can be very dangerous. They can do some complex things, some very embarrassing things too. In childhood, is very common, and it tends to be something that they will grow out of. They think it's something to do with the growth of the brain, and the brain's kind of a crazy thing. And then adulthood, it does typically taper off. Usually the number one offenders are medications, honestly. So people get put on, a lot of times it's antidepressants.
Yes,
Antidepressants, very common for causing sleepwalking. Again, marijuana, alcohol, sedatives, narcotics, that kind of stuff will relate to that. Stress is another big one. And then aside from that, there is usually sleep apnea. I hate to keep saying sleep apnea, but it's extremely common, and a lot of times we want to, at least if we can find something, fix it, get rid of it. That's good. Restless legs is another one, though, that can stimulate
what's up with restless legs?
Restless legs.
Because in my mind, I just feel somebody doing like flutter kicking at night, sticking their feet straight up in the air. You know,
you're just moving. You're restless. There's a lot. There's restless legs and periodic limb movements. So periodic limb movements are you moving your legs at night.
So there's always this moment, I feel like, at night where I catch myself, or like Betsy, like we're getting ready to fall asleep, and then there's that.
That's a hypnotic jerk.
No shit.
Hypnotic
I feel like it happens almost every night.
That is you going into N1. Okay. Totally normal.
Okay.
Light sleep, and it's you're just maybe feeling it. N1 to N2. N1's like the least amount of sleep architectures that you get. It's very quick, but it's very common for people. Hypnotic jerks, totally normal. Don't worry about them. Not restless legs. So restless legs, it is a discomfort. You're sitting, creepy, crawly, can't hold still. It can go down your legs. It can go up your arms. It can get into your neck. And medications can cause it. Caffeine can cause it. Unfortunately, alcohol can cause it. The kind of cool finding over the past couple of years is that there's a lot of work going into checking iron levels. So there's it's called a ferritin level, and it's essentially how much iron is stored in the body. And I think of like how much iron is stored in your brain, your liver, your GI system. And unfortunately, for a very long time, if you look at the normal range of a ferritin, which people don't normally check anyway, so you think iron, you think hemoglobin.
Yeah.
So you got a red blood cell, 4 hemoglobin. This is where oxygen attaches, ships through the body. Every 4 months or so, your body eats up that red blood cell, recycles the 4 iron, and you have a new red blood cell. So it doesn't need those storage areas. But if you lose blood, so unfortunately, menses, they lose blood. And so if you're losing blood, then you have to make a whole new red blood cell. So you got to take these iron molecules from your storage regions. So your ferritin levels is where that kind of comes from. And so the ferritin, if you look at the ranges of it, it was like, I can't remember, it's like 20 to 300. This is a super wide range. And somewhere somebody was like, that's kind of a wide range. That's weird. And so they were further looking at it and like, all men are above 100. I was like, oh, that's kind of weird too. And then it was cancer patients, unfortunately, who their ferritins, or kidney disease, and their ferritins, men-wise, were falling less than 100.
Okay.
And they had restless legs. And then all of a sudden they're like, all these women have restless legs. So it's kind of this evolving idea that our range of ferritin was wrong this whole time. So it's been kind of exciting to, in the past it was always like, oh, restless legs, like throw medications, they just never ever worked. And now we're finding that there may be this low grade iron deficiency. We fix it and restless legs can go away, or it can improve. It's almost like it was the body's way of being like, you need something. And just really common in women from chronic blood loss. Not as common in men. Usually it's a red flag if it's happening in men. We're like, ooh, are you losing blood somewhere? Something bad happening? And then it's very hereditary, unfortunately. It's kind of the other thing. A lot of medications cause it, though. But the pathological form is usually oftentimes the iron deficiency, which is kind of cool.
Do you find that the research in that had a little bit of a lag because it was all on men? And I bring that up because Betsy and I have talked about some of this stuff where it seems like for the longest time, all the tests, if you go back far enough, it was all just done on men, and then women were just like, well, they're the same as men, so they're going to get prescribed the same thing. They need to go through the same things that men do. We talk about it because of like athletics and stuff like that it's very different how training, especially you brought up the menstrual cycle and how different that can be for a multitude of things when you're trying to prescribe somebody something or train a certain way, or like for sleep. I mean, is it different for men and women in terms of like how you approach it, or is it similar?
I'd say it's similar as far as how well it's been researched. I honestly think the ferritin thing, it was just everybody thinks hemoglobin. Yeah. Hemoglobin is important because that's your functional iron. If that's low, like that's everybody's panicking. But I think maybe we're just getting to a phase now where medicine is starting to be pickier. I don't know. We're very spoiled. We live very healthy lives. We're living longer than ever, and so we're kind of finding these new things where it's like, oh, we maybe didn't have time or the need to really focus on these. Maybe it's a good thing with that. But as far as treating patients, no, I don't know. I think you approach everybody differently. I don't know. But there's a lot of, as far as looking at a patient, there's this, and you're coming up with all of these ideas on the age and the sex, and that will help you determine what's the most likely thing to be going on here. But again, like the male thing, if a guy comes in and I'm like, yeah, you really have restless legs, I'm immediately worried they have colon cancer or something. Like it's a thought process with that. But then you have to always test your theories and that sort of thing. I wouldn't necessarily say we treat sexes different, but definitely have different health conditions associated with.
Sleep is really in vogue right now.
It's kind of cool.
It's important. Which is pretty cool. I mean, back in the day, it used to be like, I'll sleep when I'm dead. Yes. I'm just going to grind. I'm going to grind, and I'm going to do
that was a cultural thing. The U.S. culture has always been, we don't need sleep. But they are finding, even like military-wise and stuff, they're finding that instead of making people stay up for days and days. Like, actually, if we instill enough sleep, we're more productive and less errors, and people are functioning better. And
I wish they would have done that when I was in service.
You had to learn from somebody.
Yeah.
It was a sacrifice you made.
Well, I bring up the fact that it's kind of in vogue right now, and there's all these things out there, people talking about sleep, and most of them, I mean, if you're just on social media scrolling, they're not like medical professionals or whatever, but like the nasal strips, you know, for a while, because I'm big on so how should we breathe? We shouldn't be
however
mouth
you
breathers,
want to.
right?
You have 3 holes for a reason. You need to breathe however you can.
Okay. I mean, because, so what I'm bringing up is like the narrative is shut your mouth, breathe through your nose, put on a nasal strip. I watched something the other day where they're taping their mouth shut at night.
Wild, yeah. Those are kind of fun. I mean, you're going to open your mouth, though, so...
yeah.
Also, if you were to vomit or something like that, you can aspirate. So,
right.
I don't know. The tapes, yeah. Nope, I'm not a huge fan of the tapes or the little things that go up the nose. They just fall out. You can use them, though. It is a training thing. If you're trying to treat sleep apnea or the snoring, the tape, you put the thing in the nose. It's like a one-way valve, and you have to learn to breathe in slowly. And when you breathe out, it comes out much slower, and it holds the airway open that way. Never got a patient to tolerate it, though, because you really have to train for it during the day in order for it to work at night. But if you can get them to work, that's awesome. But I have not had any success with patients yet. But if you're looking at alternative treatments, because there is the idea of, if we're talking sleep apnea, the problem is we got to get the airway open. So the PAP machines, positive airway pressure, the mask, tubing goes machine, you turn it on, delivers a pressure, your throat stays open, and you breathe. A lot of people are like, oh, I could never wear that, super claustrophobic. Actually, the couple years of wearing masks for COVID has really helped. You can walk around with that on. You're rebreathing everything. You can do a CPAP. It's a very restorative, refreshing pressure. I always think of it as if you're going scuba diving. Without your oxygen, you go underwater, you're going to suffocate. If you're falling asleep without your machine on, you're suffocating. And once you know your results and know what's happening with that, then you oftentimes have a motivation. And if I can just get you to sleep with it once or twice, like, you feel better and problem solved. Some people can't do the PAPs, though. And so we do have other forms of therapies. There is, for example, the bite guard that the dentist can make. That's much more popular now. It wasn't covered by insurance very well, so it's just an expensive device, and a lot of people are like, I don't want to do it. But that is better covered. I can't say everybody's insurance is different, though. But the way that works is it goes on the upper and the lower teeth, and there's like a hinge device. So this is your throat. Opens the lower jaw, pulls the lower jaw forward, you pop these things, and then it's basically like this. And they really have to sometimes, you can't sleep on your back with the bite guards, because your tongue, gravity-wise, is just going to fall. You shouldn't sleep on your back anyway.
Okay, that was one of my questions. Like,
that'd be a good one.
How should we be?
Just don't sleep on your back.
For real?
Yeah. But some people have to. They have shoulders, and then elevate your head. Get the little adjustable bed if you can.
Really?
Mm-hmm.
Yeah, my shoulders really hurt at night.
But if you can avoid and do the body pillows, whatever, but flat on your back, the deeper sleep you get in, especially REM, your muscles become whoop. Tongue just falls right back there.
Oh, shit. So sleep on the side?
If you can. Or your stomach. Stomach sleeping's pretty cool. Not as many people do it. Oh.
How do you... So, with the CPAP machine, you can...
Usually once you get it on and get it going, you don't move at night. That's kind of the new problem. The bed partner's like, are you alive?
Yeah.
So that's kind of cool. You might move once or twice. They have a million different masks out there. There's tubing off the front, tubing off the top of the head, so you can whirl around as much as you want. The tubing can kind of loop through the bed frame somehow. So there's a lot of, that's all kind of detail-oriented stuff. At the end of the day, I just want the throat open.
So my occasional snoring could come from my sleeping on my back.
Yeah. And maybe it's just snoring.
Maybe it's just
snoring.
Hey, Bets, maybe it's just snoring.
Maybe it's just snoring. In which case, the bite guard is an excellent choice. And unfortunately, the bite guard doesn't work as well for severe sleep apnea. It doesn't work for central sleep apnea. So it's not for everybody. But the goal is to get rid of your apnea, not just get rid of the noise of snoring. I need you oxygenating, and I want your apnea considered cured or gone in order for you to feel better. So if you have moderate to severe sleep apnea and you cannot do the machine and the bite guard doesn't work, there's a surgery they're doing right now, which is pretty cool. U of M has been doing it for a really long time, but it was $1 million workup. Insurance coverage was difficult. It was just outstanding cost-wise. But it's now better accepted by insurance companies. So we have ear, nose, throat doctors popping up all over to do this surgery. Definitely don't encourage surgery. It's like last line of defense. You have to be the special patient. But it's Inspire, or the maskless. They're advertising it a lot right now. We get phone calls all the time. But it's a pacemaker device that they implant under the right upper chest, run wiring under the skin up to about here, then a deep incision, dissect down. There's a bundle of nerves in the middle of the throat, or in the middle of the neck. They're testing each nerve until they find the one that goes to your tongue and throat, and they put a clasp on it. Sew you up. You end up back in the sleep clinic, hand you a remote control, push the button, activates the device, goes to the nerve, and the tongue tenses up. It keeps your tongue and your throat muscles tense. It is a pulsatile tension, but a constant tension. So with sleep apnea, your throat's closing off at night. We've got CPAP, pressure just holds the airway open. Then you've got the bite guard pulling the lower jaw forward, hopefully opening the airway that way. And then you've got this where the muscles literally stay tense. It's kind of crazy for
I feel like I wouldn't sleep.
Well, I don't know. We're gonna have to see. We have patients going through it right now, and it's not as easy to tolerate as, or it's not as hard to tolerate as you would think. Maybe I'm on the fence with it. Just like with anything, if you can avoid surgery, that's definitely preferable. But it is kind of cool for, like, we had a patient who had oral cancer, and so had some areas removed here. We could not get a mask on him. Sure. He's not a candidate for a bite guard. This is a great option for that patient. Yeah. So it's just like the bite guards are really good for some people, especially the younger people who are like, I'm not doing CPAP. Well, your apnea is probably mild, probably just more snoring of concern. That's a great option. But if you have moderate to severe sleep apnea, probably honestly the machine's going to be your best bet. But you do have to wrap your mind around how it works, what it's benefiting, kind of understand the process a little better.
The goal is to get people to sleep at night.
Yes.
And not have the apnea.
Yes.
So they come in, and whatever the diagnosis, whatever the prescribed is, if it's a CPAP machine, if it's a bite guard, now we're getting them to sleep. Mm-hmm. But they have issues that have brought them to this point, mm-hmm. whether that's, they're overweight, they're drinking too much, there's stresses in their life that are causing these things. Maybe they're on certain medications that are causing mm-hmm. it. What's the conversation after we get them to a point where, okay, now you're sleeping,
yes.
but you got to make some lifestyle choices.
Yes. Then the goal is, let's see if we can get off the machine. Let's see if we can get rid of your apnea. And not everybody can. Some people just have bad genetics. I have very thin people who unfortunately still have sleep apnea. But a lot of times, once you're sleeping, your metabolism's resetting. Your mood is better. Your energy is better. We do a lot with, on our follow-up visits about giving people a weight loss goal. It's only 10% of your body weight, that if you lose that, your sleep apnea might go away. So we try to talk about different diet options and different things to instill for exercise. But we always start off slow, because it's you can't just be go to the gym for an hour. No. So maybe 20-minute walks after dinner. Yep. And the whole thing is just your metabolism has basically been slowly crapping out because you've been exhausted from not sleeping. The first 3 months, you feel better. It's going to take 6 months, though, before your blood pressure and maybe your mood stabilizes, gets you off some of these medications for that stuff. That's when it's going to be I know you tried to lose weight before and it wasn't fair, wasn't easy, or it was almost impossible. For some severe sleep apnea patients, you can't. So at that 6 months mark, I'm just try those things again. Let's see if we can even get 5% body weight loss, and just kind of do some motivation there. There are medications we can use. We try not to use those. But you try to motivate the patient but they have to decide, and that's the hard part. Is like you got to find something that you're intrigued with or you want to do, and you can't overwhelm them either and be like, you got to do 100 different things. It's like the more simple, the better. But that's just a personalized conversation as far as what are you interested in doing.
So my brother has narcolepsy.
No way.
And it's funny. I mean,
or is it sleep apnea?
Well, I mean, this was diagnosed a long time ago. I think he was even he's done multiple sleep like tests and stuff like that. So this was a long time ago. I don't know if it's changed, and he's on like a sleep apnea. She's there's a bunch of things that are wrong, but like the narcolepsy thing,
it's wild. It's insane.
I mean, I would watch him just
sleep attacks. They don't even know what's happening, and your brain just is like, we're done.
So he's worked shifts since he was 18. You know, he's a couple years younger than me, but you know, how hard is it? How many sleep apnea patients do you see coming out of shift work?
Oh, a lot.
It's got to be a ton.
Yeah. Oh yeah, a lot. The shift work stuff is not easy. You're fighting your circadian rhythm.
Right.
So that's messing with your metabolism, all these hormone type stuff. But yeah, we have a lot of shift work disorders. They have sleep but circadian rhythm dysfunction is usually what it is. And unfortunately with shift work, you are fighting environmental factors, and we're kind of like, all right, this is where we probably prescribe the most medication, because it is important that they don't fall asleep driving heavy equipment or whatever it is. And so sometimes sleep aids, because they can't fall asleep. And I get it. It's noon. Like, your brain is not ready to fall asleep. But if you don't sleep, you're not going to get enough sleep to function. So unfortunately, in those instances, medications are more common. A lot of times, though, the melatonin will be helpful with that, and light exposure. Or limitations and that sort of thing. So at night, if you're waking up 2 a.m, there's the circadian rhythm lamps, which I think everybody in Michigan should have during our dark periods. But it's like a little alarm clock, and it simulates the sun coming up. So you're laying there in bed, and your brain's thinking, look at that. It's 6 o'clock in the morning. And you can set your circadian rhythm that way. So that's the ultimate goal, but a lot of times we do have to, especially their shift work, it's like they're flipping and flopping, and it's like, oh my gosh, that is so hard to do. I don't know how they do it, but I do think physically, unfortunately, they suffer.
So the circadian rhythm lamps,
great for kids too.
Kind of mimics sunshine,
yes,
in a way. Okay, because that's the one thing I've been reading a lot about that, listening to podcasts about when we talk about sleep, and like, first get that vitamin D in the morning as fast as you can. Get outside and get in the light. Well, like you said, we live in Michigan.
It's so hard. In February, everybody comes in. It's like, am I depressed? Am I not sleeping? I'm like, we're solar powered. It's not easy to live in the dark months, especially because electronics now are really screwing up things like the TVs and the phones, computers. Are like, what are TVs now, like 70 or something? It's crazy when you look. Like, I don't even know, but it is a bright light. The tech people know what they're doing. That goes directly in our brains and turns on those awakening centers. So we're kind of going about our days. Everything's dark and dreary, and we're sluggish. We get home, super dark, so we turn on all the lights. And all these lights are super stimulating. It literally is changing people's circadian rhythms so that you're not sleeping good at night. And that's a big deal. And that's where the electronic stuff comes in, where everybody knows it. We shouldn't be on our electronics, and especially kids, though, they are so sensitive to this. Is so important. If you're needing them, I mean, they can sleep whenever they want to sleep. I guess that's one thing. But if you're needing them to get up and function for school, you really need to be setting that and doing it yourself too. But like an hour or two before bedtime, at least start decreasing turn the lights off, turn the TV off, turn that bright light therapy off, because you don't want it at night. You want the deserted island thing where the sun's coming down, your melatonin's releasing, your body's getting ready for sleep, but instead it's almost like we've switched it.
TV's in the bedroom.
But everything's brighter.
Okay, so like I'm not trying to say that we're the parents of the year, but like, so we don't do the technology stuff at the house, whatever. But like at night, a few nights a week, excuse me, and we've talked about this before, Mary and I will watch a show at night. And it might only be 45 minutes, but it's pretty much before she goes to bed. So we've had dinner, we're winding down, turn the TV on, we watch this half-hour, 45-minute show, and then she'll go and read with Betsy for like 15, 20 minutes. Yeah. And then she goes to bed. But that's not enough time between watching.
If she's falling asleep, you're good. And just, as far as like the TVs go, maybe your TV's not the 7D that's really bright and hyper stimulating, but I feel like a lot of people are sitting there on their phones or iPads. They have the TV, then they've got, have you gone by light bulbs lately? It's super overwhelming. It's like
the amount,
and there's bright light and every time I'm attracted to the white light, and I'm like, no, don't. You want dimmer lights, or just turn the lights off. So even like bathroom lights, kitchen lights tend to always be that really bright, stimulating, and we're turning those on at night. So it's not just TV, and it's not just it's a matter of just maybe the energy in the house. But the light exposure, I think we all need to be, especially in the winter months, extra careful with. And the opposite, when you're getting up, especially if you got like an office you sit in or something, you should invest in one of like the bright circadian rhythm lights. And as much light as you can get upon awakening until 10 is the best way to set your set your circadian rhythm. Natural light is the best though. Sure. Honestly, I wish Michigan would just shut down in February. Everybody go south. And everybody would be so much happier. I'm a big complaint. Talking to my friend who works at the school, I was like, can we change spring break to February? She's like, no.
Yeah, sure.
Like I get, like but in theory, that would be cool.
One of the since we're on that, one of the things I want to talk about is like vitamin D, hormones. Is a vitamin D supplement something that can help?
Sure. Yes, and some people are very sensitive to vitamin D. It's not going to be your circadian rhythm, though. That's more of a fatigue factor.
Okay.
But I mean, if we checked everybody's vitamin D in the winter months, I'm sure it's low. You get your best vitamin D from natural light exposure, just 15, 20 minutes. But we don't even, I think there was 1 year, I didn't check this year, maybe it was last year, in January, we got 4 hours of sunlight for the month in Michigan.
Yeah, we were all kind of in the shitter.
Big deal. And everybody thinks they're depressed. They're going on antidepressants. I'm like, no, you just need to go to like Florida or something for a week or two. Honestly, get out of here. Go get some natural sunlight. And we do like the circadian rhythm alarm clocks and stuff. The Hatch is the one the celebrities all use. It's like $100, but there's cheaper versions than that. And it helps. It's just not the same though. Like sun, absolutely. I don't know. We are solar powered.
Yeah.
But with this, I guess I forgot where we started with this.
No, it's vitamin D. We're just talking about vitamin D and getting vitamin D.
Oh, so the sun increases your vitamin D. That's going to give you daytime energy, but not so much. And some people take vitamin D at bedtime. I can't.
Okay.
It does. I don't know why, but for me, I can't sleep.
Because I try to get outside as much as possible. I take vitamin D year round. But I tend to do it like I take like a athletic greens in the morning, and then in the afternoon, like 2 or 3 o'clock, I'll take some vitamin D. I'm inside all day.
Yeah, as long as you're not having a problem. That's early enough, I would think. I just know I can't take it at bedtime. Some people can though.
It kind of lifts you up a little bit.
Yeah, maybe too much energy.
What about like cholesterol? People on statins, does that?
The statins are known for causing muscle achiness, and so I mean, I've had people having pain at night and the achiness, just like arthritis stuff, and I didn't even come up with it, but they got switched or something like, oh, it all went away after they switched it or whatever they did with their primary care. So they can impact it.
So to wrap this up, most insurance can help with this.
With
getting you to sleep study, getting you on.
Sure. Yeah. Insurance companies tend to shockingly like sleep.
They want you to sleep
Because it's cheaper to pay for that stuff than a hospital stay from a stroke or a heart attack or those type of. The coverage is I don't know. Insurance coverage just honestly stinks right now as far as commercial insurances go. It's high deductibles and high copays. There are ways of going about it as inexpensively as you can. And so I guess an in-office sleep study is an expensive test. There's a lot of monitoring going on there. And for some people it's necessary. But for a lot of people we don't have to do that. It does have to just be kind of personalized per the person. And I would definitely say if you have concerns with your sleep, discuss it with your primary cares, your providers, and see if they think it's necessary. Not everybody has a sleep problem though, so it's not like everybody needs to go to the sleep clinic or anything like that.
Is there anything else you want to talk about while you're here? This was awesome, by the way.
That was fun.
A ton of information.
No, I'm good.
Yeah?
Yeah.
Thank you so much.
All
That was
right.
great. Perfect.